Our next speaker is Ji-Taek Hong from Seoul in Korea for the Ewha Women's University College of Medicine. Go ahead, please.
Good evening, ladies and gentlemen. It's an honor for me to speak at this meeting. Today, I'd like to present you with the research on the clinical features and outcomes for bleeding after endoscopic resection of some mucosal invasive colorectal neoplasms and the risk factors for bleeding. Endoscopic resection is an effective and safe treatment method used for the treatment of superficial colorectal neoplasms, including precancerous lesions and early cancer, and has relatively less invasive and good clinical results. However, post-operative bleeding and perforation are major complications of endoscopic resection. In particular, bleeding may occur over time than other complications, and additional treatment may be needed after discharge. In addition, bleeding after some mucosal resection may cause serious complications such as hemorrhagic shock. Therefore, identifying the risk factors for bleeding after endoscopic resection is important for predicting the possibility of bleeding before the procedure and to respond appropriately in case of complications. Next. Bleeding can be divided into intraprocedural bleeding and delayed bleeding depending on the timing of occurrence. Uncontrolled intraprocedural bleeding has the potential to result in serious morbidity, and difficult to control bleeding may result in prolonged procedure times and compromise resection accuracy. Delayed bleeding also can similarly result in significant morbidity. While many studies report the incidence of bleeding, most of the studies were limited to single institution of a small subject, and various definitions of bleeding have been used. The incidence of bleeding was not sufficient to evaluate the risk factors due to the significant heterogeneity. And there is little research on bleeding during the procedure. In addition, most of the current study on bleeding risk factors include various types of adenoma, intraepithelial cancer, intramucosal cancer, and some mucosal invasive cancer. Some mucosal invasive cancer includes only a small number of subjects, and further studies on single-cell mucosal invasive cancer are needed. Therefore, this study is a multicenter cohort study based on a single subject of some mucosal invasive cancer. The purpose is to investigate the incidence of and its clinical outcomes of bleeding and to analyze the risk factors of bleeding. Firstly, we'll take a look at the definition of the bleeding used in this research. Intraprocedural bleeding and delayed bleeding, and major bleeding and minor bleeding. Retrospective cohort study was conducted at 10 hospitals in the Republic of Korea. A total of 986 submucosal invasive colorectal lesions were finally analyzed. The risk factors for post-endoscopic resection bleeding were assessed from data based on patient, treatment, and region-related variables. If we take a look at the baseline characteristic of the two groups, according to the presence or absence of bleeding, the drinking, smoking, endoscopic lesion size, and pathological lesion size was significantly greater in the bleeding group, but other variables did not show any significant difference. We'll take a look at the results. Procedure-related bleeding occurred in 109 out of 986 lesions, showing 11.1% incidence. The overall rate of intraprocedural bleeding was 8.2%, and delayed bleeding was 2.6%, and major bleeding was 3.2%. All cases of bleeding have been successfully managed by endoscopy, conservative observation, and angiography without surgery. No death from endoscopic resection-related bleeding was observed during a median follow-up period longer than 4 years. When looking at the overall bleeding that occurred, the multivariate analysis showed that the odds ratio for pathologic specimen size was 1.026, which was significantly related to bleeding. When looking at the intraprocedural bleeding, the multivariate analysis showed that the odds ratio for pathologic specimen size was 1.024, which was significantly related to bleeding. As for the delayed bleeding, the multivariate analysis showed that the odds ratio for anticoagulant use was 7.833, which was significantly related to bleeding. When looking at the major bleeding, the multivariate analysis showed that the odds ratio for ESD was 3.244, which was significantly related to bleeding. In conclusion, while the procedure-related bleeding was at 11.1%, the intraprocedural accounted for the majority of the cases, while delayed and major bleeding only accounted for 3%. All bleeding that occurred were treated without surgery, and no bleeding-related deaths occurred. Therefore, it has been shown to be relatively safe for bleedings after endoscopic resection of some mucosal invasive colorectal neoplasms. An increased risk of intraprocedural delayed and major bleeding was associated with pathologic lesion size, the use of anticoagulant medicine, and ESD treatment method, respectively. Therefore, prior to endoscopic resection for some mucosal invasive colorectal neoplasms, these risk factors should be checked in advance, and for high-risk patients, carefully monitoring and cope with possible complications should be considered. That's it from me. Thank you for your attention.
Rodrigo, I feel that we need to pay tribute to the Korean group because they took so many data from this KASID study. So my question to you is, can we use your risk factor to decide when to clip or not to clip after an EMR in colonoscopy?
So I have I'm the translator for Dr. Hong here. So could you just repeat your question again? We didn't quite catch that. I'm sorry.
Can we use this risk factor to decide when to put clips after endoscopic resection in colonoscopy?
Okay. 지금 이 리스크 팩터들을 가지고 그 엔도스코피 한 다음에 클립을 하는 거를 결정할 수 있냐고 하거든요.
보통 아직 클립으로 하는 거에 대해서 딜레이드 블리딩을 예방한다는 논문들이 있지만 아직 완전히 밝혀져 있는 것은 없습니다.
클립을 하면서 블리딩 예방한다는 건 있지만 아직 확실한 건 없어요. There are some evidences that that shows potential connection or relationship in between use of clip and the reducing the bleeding, but it hasn't been properly confirmed yet. So it's still in study.
그래서
Thanks so much.